Super eye palsies. This lecture, I wanted to talk about cranial nerve palsies that involve the eye, specifically cranial nerves 3, 4, and 6, and how they cause double vision, and how to recognize that in our patients. Now, when I was a medical student many years ago, I struggled with several topics, and one of those topics was neuroanatomy. I found it extremely confusing. The nomenclature is bizarre. I mean, there's afferent, efferent, primary, first, second, third order neurons. It's just very confusing for me at the time. It's totally different than anything I'd ever studied to that point. And one of the things that particularly confused me were the cranial nerves. You see, the head is innervated by 12 different cranial nerves that come off the base of the brainstem. And each of these nerves does something different. Now, they're easy. Some of them are. Cranial nerve 1 does smell, 2 does sight, the optic nerve, and number 8 does hearing. But it's the cranial nerves that innervate the eye, specifically cranial nerves 3, 4, and 6, that were the most confusing because they innervate the 6 different muscles that control eye movement. And these muscles are confusing, especially for a student, because each one of them has a primary, a secondary direction of action, some type of rotational component. And I thought that this must have been very important material. In fact, I remember as a student, I would walk around the hospital, and I would have this little handy chart that I kept in my pocket that had a listing of all of these different muscles and exactly what they did. And the superior rectus, what was the vertical, what was the horizontal, what was the torsional component. If you tilted the head, what happened to each of those muscles. Face turns, chins, head tilts. I thought this must be very important, and so my focus at the time was minutia. Let's look at this little stuff. You got to understand the minutia before you get the big picture, and that was my approach. Unfortunately, after 4 years of med school, 4 years of ophthalmology surgery training, 4 years in private practice, I realized that minutia is extremely unimportant. It was one of those situations where you can't see the forest for the trees, because the reality is cranial nerve palsies that involve these eye muscles fit certain patterns, and recognizing these patterns from a higher altitude is more useful as far as diagnosing and treating real patients on a everyday basis. And so what I'd like to do is give you my simplified approach to evaluating cranial nerve palsies that involve the eye muscles, and sort of how I view this and how to treat as well. So we're going to do this in 2 parts. The first part of this lecture, I'm going to basically do the basic science. What are the muscles? What are the cranial nerves? What do they cause? But the majority of this lecture is going to be patient examples. What do patients look like in real life when they present with these problems? And some pearls on how to treat and what to look for. So let's begin with eye and nerve anatomy. And the first thing you need to realize is that the eyeball sits inside of the eye socket, kind of like a scoop of ice cream inside of a waffle cone. And there's 4 muscles, the rectus muscles, that control most of the eye movements, up, down, left, and right. And if the eye socket was this simple, this would be extremely easy. The problem is nature has added a layer of complexity and created oblique muscles. And these oblique muscles attach in a funny direction and create rotational components. And the most important, of course, is the superior oblique on top. If we look at the cranial nerves, the third cranial nerve is the main nerve that innervates the majority of all the eye muscles. It comes off the brainstem, innervates the superior rectus, the lateral rectus, the inferior rectus. It also innervates the inferior oblique, a funny little muscle on the floor that creates some rotational component. The third nerve also innervates the levator muscle. That's the muscle that pulls the eyelid up, especially important when you're looking up or when you're trying to open the eye. And finally, the parasympathetic nerves that control pupil constriction run along with the third nerve as well. So a lot of stuff. Now, if you're thinking to yourself, how am I going to memorize? That's a lot of things to list out to memorize. It's probably easier just to think about what the third nerve does not innervate. So what happens if you have a palsy to that nerve? Well, if that nerve stops working, you lose the majority of the muscles of the eye, except for the lateral rectus, and the eye has a tendency to turn out, the superior oblique, which pulls the eye down, and you get a droopy eyelid. In addition, you may have a blown pupil if you lose the parasympathetics as well. So a down and out eye. So these patients fit a pattern. You don't have to memorize the details. You look for the pattern, and the pattern is a third nerve palsy is down and out with a droopy eyelid and potentially a blown pupil. So what are the causes? All of the cranial nerves, all of them. The number one cause is some type of vasculopathic problem. And when I say vasculopathic, I'm usually meaning some type of diabetic ophthalmoplegia. Diabetes, problem with blood vessels, all that sugar makes them leaky. They can sometimes cause mini strokes to the nerve itself. Another vasculopathic issue is high blood pressure. So diabetes and high blood pressure are by far the most common cause of most of these cranial nerve palsies. The second, not maybe the second most common, but one of the things we have to look for because it's dangerous is tumors. So you always think about tumors with any new cranial nerve palsy. But the special one with the third nerve is aneurysm. The anatomy of the third nerve is such that it's very close to a couple of blood vessels underneath the brain, and an aneurysm can push on the nerve. And And if an aneurysm pushes on the outside of the nerve, that's the place where those pupil fibers are. So if we look at a cartoon drawing of the third nerve, the parasympathetic fibers that control pupil constriction, they actually run on the outside of the nerve. So if you have a compressing lesion from the outside, it usually pushes on those. So when you see a blown pupil, it's never a good thing. You got to think about tumor and especially aneurysm with a third nerve palsy. The sixth nerve, we're going to skip straight ahead to the sixth. It comes out lower down the brainstem, makes a funny turn, and it innervates only the lateral rectus, and that makes the eye move outwards. But once again, it's probably easier to look for the pattern, what happens with a sixth nerve palsy. If that sixth nerve goes out, you lose the lateral rectus, and the eye has a tendency to turn in. So a sixth nerve palsy causes a crossed eye. And so that's what it looks like, a crossed eye. These are pretty easy to diagnose. They got a crossed eye, and the eye doesn't want to move out. And what are the causes? Once again, vasculopathic. Start thinking about diabetes, hypertension. You also think about tumor. But the special one that I want to emphasize with these sixth nerve palsies is you can also see this with high intracranial pressure. Something about high pressure inside the skull causes problems with that sixth nerve. And you can think of the brain sitting inside the skull. It's sitting in CSF, cerebrospinal fluid. And that fluid's very similar to aqueous in the front of the eye. In fact, they have almost the same content. And the medications we use to lower pressure, like Diamox, they work for the brain as well. But high pressure. And we think that something about the funny turn that the sixth nerve makes as it pops up and then makes a sharp 90-degree angle going through the cavernous sinus directly into the back of the eye socket, something about that maybe makes it predisposed to high pressure pushing or compressing the nerve. Moving on to the fourth nerve. This is the hardest one. This nerve actually comes off the back of the brainstem. The only nerve that does that. It takes a very long course and innervates a single muscle inside the eye, which is the superior oblique, the most confusing eye muscle palsy of all time. Because the oblique muscle has two actions. It pulls the back of the eye so that the eye looks down, but it also creates a certain amount of intorsion and spins the eye. And the problem with this muscle is that the direction of movement depends on which way you're looking. So if you imagine that if the eye is looking inwards towards the nose, you get more of an up-down, and if it's looking outwards, you get more of a side-to-side. And you can simulate this self by pretending your eyeball is a big giant, your head's a big giant eyeball. And if you take your arm and you wrap around your head, this is basically the action of the superior oblique. And if you look to your right towards your elbow and pull, it's an up and down. But if you look sideways, it's more of a side-to-side action. And that's pretty much what this muscle does. This is basically an animation showing that. So in primary, it's hard to see what's going on, but if you look towards the nose, you get more of an up-down action, and if you look laterally to the outside world, you get more of a twisting and torsion action. So it kind of depends where you're looking. But this is confusing. As a med student, this is the type of thing I would try to memorize, and it just didn't work. It's easier, I think, to think about what happens with a palsy. With a fourth nerve palsy, you'll lose that muscle action, and you see the following. The eye twists a little bit. That's hard to see, but the eye shoots up. It shoots up when you look nasal. We call this a nasal upshoot. If you forget everything else from this entire lecture, a fourth nerve nasal upshoot is going to be the most important thing. So that's what it does. That's a lot easier to memorize than anything else. So with the fourth nerve palsy, once again, what causes it? Like all the other ones, vasculopathic. You look for diabetes, you look for high blood pressure. You also look for tumor. It's a very long, skinny nerve with a very long course through the cranial, through the head. So a lot of places a tumor can compress. But there's a couple of special ones we look for with fourth nerves, and one of them is congenital. It's such a small, little, funny little muscle that a lot of kids have a congenital palsy, but they develop stronger muscles to compensate, and you don't really see it except for maybe a head tilt. And trauma is the other thing we look for. It's a skinny, long nerve, and it can easily be damaged by head trauma. So, 3 different patterns. A third nerve, down and out. Think about aneurysm, especially with the pupil being dilated. A sixth nerve has a crossed eye. Think about increased intracranial pressure. And finally, the fourth nerve does that funky nasal upshoot. And think about congenital, especially if they have a head tilt. They tend to tilt away from the side of the problem. And also trauma, because it's a long, skinny little nerve that gets damaged easily. Now, most lectures, I think, would stop at this point because we had the knowledge, we had some pretty good animations, and that's that. But it's very hard sometimes to translate theory into real life. And so what I'd like to do is show some actual patient examples. And so that's going to be pretty much the rest of this little mini lecture. But I would like to make a quick disclaimer. Some of these patient examples may be slightly humorous or somewhat flippant, and I don't mean this to disparage our patients or to minimize the severity of these ocular problems. I know this crowd understands this, but if this goes up online, there's going to be a certain number of people who are somewhat insulted by this approach. But I personally have always found that humor is one of the best ways to teach medical people. It maintains attention, it increases retention, and hopefully this will help us better take care of our own patients. So take this all with a grain of salt and with the intention I did when I made this. So patient examples. Now, I have actually a lot of videos of various patients I've seen over the years with these palsies who have allowed me to take videos of them, but I'm hesitant to put them online for patient privacy issues. And so instead, what I did, what most medical schools do, is I hired an actor. Unfortunately, I couldn't hire very many actors, and so we'll have to make do with our talent, but fortunately a very wide range of skill. So let's begin with our first, what I call a super patient, and we'll see what he can teach us about eye problems. So our first patient is a 55-year-old philanthropist. He's also a power worker and enjoys midnight walks on the beach. He's here because he's complaining of double vision for the past couple of days, side by side. For the most part, he's healthy. He does like coffee, and he is addicted to energy drinks. And he does tell us that his blood sugar has been kind of borderline, but he attributed it more to some steroid injection he's been getting in the knee for some chronic knee irritation. So let's look at his eyes and see what we see. Looking at his eyes, close up, and primary, perhaps something wrong with that right eye. It does not seem to be moving nearly as well as the left. Let's look in all the cardinal directions, and we can see that the right eye has a problem. And it appears to be down, and it appears to be out. So what is this? It's probably a cranial nerve 3 palsy, right, of some sort. So we have a 55-year-old gentleman, probably diabetes, a right third nerve palsy with no pupil involvement. So what's our differential? We've already gone through this before. Vasculopathic is by far the most common. We think about diabetes, doesn't have high blood pressure, okay. Tumor, maybe. I mean, the third nerves make me kind of scared. That's a lot of eye movement problems, so maybe. Aneurysm, possibly, but we didn't really have a pupil involvement. So what kind of workup do? We probably want to image this gentleman to rule out some type of mass lesion, tumor, aneurysm, and see how he's doing. The learning point here, though, is the following, though. You know, diabetes, high blood pressure can cause problems to the nerves. The little axons that run through those nerves become damaged, and they'll kind of wither away. But the overlying basic structure of the nerve itself is still there. And so these peripheral nerves can regrow back, and they regrow over the space of 3 to 6 months. So many times after a vasculopathic incident like this, the eye will recover. This is different than trauma. Trauma or compressive lesion will mess up the underlying structure of that nerve, so when the nerves grow back, they may not be able to hook up to the correct muscles properly. You'll get aberrant regeneration. So, moving on. Super patient number 2. This gentleman, he is a 45-year-old X-ray tech, and he's here for a third opinion about his double vision, and he's not very happy with us. We all have patients like this. They're angry from the moment they enter the door at us. He's angry because he's had headaches for the past month, and he's also complaining of double vision for the past several weeks. He's seen several eye doctors but doesn't like their opinion. He does work in the X-ray, but he protects himself with lead-lined suits with no problems. He doesn't really have any medical issues, but he does have some high blood pressure problems. His psychologist thinks it's related to anger management. So, looking at his eyes under the microscope, we see the following. It looks like perhaps something is going on with that left eye. It looks like it's down and out. It looks like perhaps the pupil is blown. And perhaps even the eyelid itself is drooping down on that left-hand side. So what is this? This is pretty obvious, right? It's a third nerve palsy involving the pupil. 45-year-old gentleman, high blood pressure, headaches, pupil involving third nerve palsy. What's on our differential? Once again, we go through our list. Vasculopathic. He's got high blood pressure. Okay, maybe. Tumor, maybe. Aneurysm, very high chance. That pupil is blown. There's always a chance something is compressing that eye. So our learning point here, though, is, as we've already stated, the third nerve carries most of the muscles, but the fibers controlling pupil constriction run on the outside. So if you imagine this yellow balloon is the third nerve, if there's a compressive lesion, it tends to push from the outside and you blow a pupil. A blown pupil is always an ominous sign no matter what happens. So we image these and we treat it. Moving on, our third patient. This is an 82-year-old gentleman transported over from the local nursing home with complaints of double vision. He missed his ride and is 2 hours late, but he finally showed up, and we're ready to see him. He doesn't have much medical problems. He does have high blood pressure, but that's getting better because he's lost some weight recently. He's seeing double when he uses the computer, but he's also noticed that he's having some pain every time he brushes his hair. He has many complaints, but this is just one of many. And overall, just not feeling that great, but double vision, side by side. Looking at his eyes under the microscope, we see the following. Primary, okay, but something going on with his right eye. It doesn't look like it's going out as well as it should. So perhaps this is a right nerve 6 palsy. So here we go. We have an 82-year-old gentleman, high blood pressure, general malaise, not feeling great, with a 6 nerve palsy. What's on our differential? As always, we go through our list. Vasculopathic, diabetes, high blood pressure. He's got high blood pressure. Okay, well, that could be it. Tumor, maybe. It happens. Cranial pressure, he's not really complaining of neck stiffness or chronic headaches, but maybe. But here's the issue. This is a, 82-year-old gentleman who's having malaise and maybe some scalp tenderness. You always have to think about things like temporal arteritis. Any person you have who has a new neurologic finding, either with the eyeball or the eyeball muscles, who is over, say, 60, 65, consider temporal arteritis. When you look for the classic symptoms, jaw claudication, scalp tenderness, general malaise, achiness of the muscles of the neck and the shoulder, weight loss, night sweats. And as we know, temporal arteritis is when you have an inflammation and itis of the arteries around the head, and if they become inflamed enough, they will close down and cause almost a mini stroke, and very dangerous. So we start him on steroids, we get an ESR, CRP. If these things come back negative, we start looking for mass lesions and see if he recovers with time. Next patient, number 4. Our next patient is a 29-year-old young woman who's been complaining of double vision and headaches for several months. She is a truck stop waitress, but she also is a part-time stunt pilot. But she's having double vision all the time now, except when she's reading, and she's also complaining of headaches. For the most part, she's healthy. She doesn't have any diabetes or high blood pressure, but she does tell me that she has gained a couple pounds since giving birth to her last child and has been on antibiotics for chronic sinus infection. Looking at her eyes, we see the following. Pretty obvious here. The eyes look crossed. But what's the problem? Which eye is it? Could it be both eyes? Could this be a bilateral 6 nerve palsy? Perhaps. That's sort of what this looks like. Neither eye can abduct outwards, which looks like 6 nerve palsy. So, what's on our differential? We have 29-year-old woman, headaches, recent antibiotic use, 6 nerve palsy in both eyes. Once again, we go through our differential. Vasculopathic, she's young, doesn't have diabetes, doesn't have high blood pressure. Tumor, maybe pretty young to have a tumor. But could this be increased intracranial pressure, high pressure in the brain causing her headaches? Perhaps. Looking in the back of her eye, we look at her optic nerves, and they look somewhat full and swollen to us. Obviously, you're not seeing this in 3D, but this is kind of pouching outwards. Both eyes, papilledema. We pretty much have clinched our diagnosis of pseudotumor cerebri, and certain things seem to set that condition off, including antibiotic use, recent weight gain, and is much more common in younger women. So we treat with Diamox into neurology, and she gets better with time, and we monitor to make sure she doesn't develop any visual field losses. Our learning point here, though, is the following, is that high pressure inside the brain itself can cause a 6 nerve palsy, perhaps related to how the 6 nerve makes that funny angle before popping into the cavernous sinus and eventually into the eye socket itself. Very good. Our next patient, number 5. This is a 58-year-old gentleman. Didn't want to come in, but his wife kept pestering him to show up. He has an interesting job down by the seaside. He works at the local lighthouse as a lighthouse keeper, and he's complaining of double when he looks at boats in the distance from the top of his lighthouse. So basically, when looking at sailboats on the horizon, he's noticed that he's seeing double, not side by side so much, but more of an up-down double vision. Not all the time, but he's been seeing this more and more of late and is obviously a little concerned. Reviewing his history, it sounds like he does have some high blood pressure, but no glycemic problems. He's a vegetarian and only eats green leafy vegetables. Looking at his eyes under the microscope, we see the following. For the most part, looks pretty good, but you guys see anything funny going on here? Is something going on with his left eye? Watch carefully. It's hard to tell. These things are subtle. Is that left eye, is it shooting upwards? Could that be a nasal upshoot on a right gaze? Perhaps. This looks an awful lot like a fourth nerve palsy. So here we have a 58-year-old gentleman. He's got high blood pressure and a new fourth nerve palsy. What's on our differential? Well, once again, we go through things: vasculopathic, diabetes, high blood pressure. He does have high blood pressure. Tumor, possible. Congenital, well, he doesn't really complain of a head tilt as a child. And trauma, he doesn't really have any. So maybe vasculopathic. Do we work this gentleman up? New fourth nerve palsy, I probably image just to rule it out, but hopefully this will get better on its own. But our learning point is the following, is that fourth nerves have a tendency to create a nasal upshoot. That's what they do. So once again, if you remember something from this lecture, memorize this silly video. Our next patient, we're getting near the end. 83-year-old gentleman, surprisingly good health. He's a self-defense coach. He's also an avid athlete and an avid golfer. He's coming in complaining of double vision. From his story, it sounds as if he fell off of a golf cart recently. And when he did that, he landed and hit his head. It wasn't a bad injury. He wasn't knocked unconscious or anything. But ever since then, he's been complaining of double vision when golfing. After he hits the ball, he notices two balls somewhat catty corner in the distance. In addition, he's feeling a little unstable when he's walking down the steps, and otherwise is healthy. Maybe some borderline high blood pressure. Looking at his eyes, we see the following. In primary, looks pretty good, doesn't he? Left and right, no problems. I don't see anything there. Let's look for that nasal upshoot. Do you guys see it? I don't see it. Maybe it's there. Maybe not. These things are really subtle. They're hard to see. Fourth nerve palsies are very challenging. So we think perhaps there's a nasal upshoot. Let's do a cross-cover test, and we'll see if we see any eye fixation movements. Watch that right eye. Is that right eye coming down a little bit? Could this be a slight right hypertropia? Maybe. Once again, subtle. And you can't always tell which eye is going up, which is going down, but there's some type of vertical deviation. We think it's the right, but what else can we do to tease this out? Well, one of the tests I like is the subjective Maddox Rod test. This is that little red plastic doohickey with the ridges. If you line that thing up so that the ridges are vertical, you'll get a horizontal line with a pin light through it. And so what I'll do is I'll have my patients hold this up to their right eye, and I'll say just hold it over the eye at this angle, keep it the right angle, and I'm going to hold this pin light up, and I want you to look at this light and tell me what you see. And normally, what they ought to see is something like this. You're dissociating the eyes, but if they're in good vertical alignment, both eyes are looking straight, one's not deviating, the red line and the light itself should be touching. And you can move that light around. It shouldn't change that at all. They should still be pretty much touching and together. So this is what a normal subjective Maddox Rod test is, and it's good for vertical deviations in particular. So, but we think this gentleman has a right hyper. We think that the right eye is drifting upwards, right? So what would you expect to see on this test? Well, if the right eye is looking up, what he's seeing ought to look down, because if you look over an object, the object should look down in your vision. So what we ought to see is something like this, an abnormal Maddox. So we say, describe what you see. He says, I see the red line is down below. Always ask him what's the red line doing. Focus on the right eye. You'll get confused otherwise. The red line is down below. Okay, well, what happens if I move it around? Well, they get closer when I go over here, but it seems like when I go over here, and he looks in that direction, they get further apart. So closer over in one direction when he turns his eyes to the right, more normal. When he turns his eyes to the left, less normal. And what does that mean? That means most likely that the right eye is becoming up when he looks off to his left. That sounds like a nasal upshoot of the right eye. So we think this is a right fourth nerve palsy. So, in summary, we have an 83-year-old gentleman, high blood pressure, trauma, hit the head. We think it's a right fourth nerve palsy. What's on our differential? We go through the list. Vasculopathic, he's got high blood pressure. Okay, maybe. Tumor, possible, maybe, given his age. Congenital, unlikely. He's never complained of this before, and we have an event that's caused this. And finally, trauma. But there is one more thing we didn't consider. He's what, 83? Got to think about temporal arteritis. But most likely, a traumatic fourth nerve palsy. And our learning point with this gentleman is the following. The fourth nerve is the only nerve that comes off the back of the brainstem. All the other ones come off the front. Fourth is the only one that comes off the back, and it's real skinny, it's real long, and trauma can sometimes rip that nerve out, and that's why fourth nerves and trauma kind of go hand in hand. Our last patient, a young man. His mom forces him to come in. He's 23 years old. He's a student up at Columbia University in New York City. He's studying entomology and wants to become a behavioral psychologist or some type of zoologist. But he's here because he's been complaining of some general eye strain and irritation. When he reads for prolonged periods of time, more than, say, 15 minutes, he's getting headaches and maybe some double vision, maybe one on top of the other. He's not the greatest historian when it comes to this. Very vague complaints. He also complains of a little bit of headache as well. So we look at his eyes, and let's see what we see. Primary looks pretty good. Let's hit the cardinal directions, see how he does. So far he seems okay, right? Okay, let's do some cover on cover, maybe some cross cover testing. Let's see if we can pick up any eye movements. You guys see any? It's moving a little bit, right? But is it consistent? I'm not seeing much. This is what most people presenting with double vision look like. They don't look like much. So what's the next test we can try? Well, we can go to our handy-dandy subjective Maddox Rod test. And but here's the next problem. He doesn't understand what you're saying. He's like, what? Red line, white line? I don't see the light. I see 3 lines. That's what most people do with subjective Maddox Rod. You have to have a certain personality to understand what's going on. And so he's confused. But we're looking at this guy, and we're saying to ourselves, what could be going on? But do you notice anything funny about him right now? Does it seem like he's doing anything? Is he tilting his head slightly to one side? Could this be a head tilt? Has he been tilting the whole time I've been testing him? Maybe. So what do you do if you have a head tilt? Well, you take your hand, you push their head over, and you repeat all your testing, and you see if you can pick up something new. So what do we see now? Is that right eye shooting down? Is this a right hyper that we are only picking up once we force the head over? So maybe. So we have a head tilt to the left, a right hypertropia. So that sounds an awful lot like a right fourth nerve palsy. So once again, 23-year-old, fourth nerve palsy. The question is what causes it. So we go through our differential. As always, vasculopathic. Diabetes, high blood pressure, he doesn't have it. Tumor. Kind of young to have a tumor, but possible, I suppose. Trauma, he has no history of trauma, but congenital is probably the one that's most likely, and certainly in youth, fourth nerve palsies, majority of them are congenital. But how do we tease that out? How do we know if it's congenital? We don't know. A couple of things we can try. One is to look at his old photographs. Look at his license. And you see he's got a little bit of a head tilt. Now, this license is only a year or two old, but this sounds like it's been there for a much longer time. Another thing we can do is look for vertical amplitudes. Basically what we do is you hold prism up that have an up-down, base up, or base down in front of their eye, and you see how much vertical they can handle before they get double vision. And most of us can only do 1 or 2 diopters of vertical prism before we get headaches and get double vision. But if your eyes have always been out of alignment, your whole life you've been straining to keep things back in alignment, you can handle a large amount of prism, maybe 8 or 10 diopters, before you start getting double vision. And that usually indicates that this has been going on for a long period of time. So vertical vergence or amplitudes is what we call that. But our learning point here is that something subtle like this, it's always useful to look at old photographs and see if you can pick up some type of subtle left head tilt. And they'll deny it, but you look at the photographs and yes, indeed, it's always been there. Fair enough. So in summary, we've learned that the third nerve innervates most of the eye muscles, and when it's out, the eye turns down and out with a droopy lid. And if the pupil is involved, it could mean an aneurysm pushing on that nerve. We've learned that the sixth nerve controls only one muscle, the lateral rectus, and when it goes out, you get a crossed eye. And one of the potential causes, especially with bilateral sixth nerves, is high intracranial pressure. We've learned that the fourth nerve, funny little nerve, long and skinny, when it goes out, it creates a nasal upshoot. And there's a couple of causes, including trauma and some type of congenital thing, which could cause a head tilt. The reality, though, is that neuro-ophthalmology is incredibly scary. This is the only area in ophthalmology where we have potentially deadly diseases going on. Tumors, aneurysms aren't necessarily funny. But I hope that you found this approach useful for learning this material, and hopefully this more humorous approach allows this material to stick in your brain a little bit easier than the traditional method, and ultimately allows us to better serve our own patients when we are presented with these problems. Thank you.